Well, greetings everyone, and welcome to the EKG case for the week of October 21st, 2013. This week's case was sent to me 1 week ago by Dr. Sean Fox and a colleague that he was working with, Dr. Musi. I hope I'm getting that name right. Dr. Sean Fox is a graduate of our Combined Emergency Medicine Pediatrics residency program and has become an educational superstar at Carolinas Medical Center. And, well, Sean, let me just say that if you ever decide to come back to Baltimore, we've got a spot for you. But anyway, Sean was coming off a night shift and was going to be heading off to ASEP. In fact, he sent me this case early in the morning as I was just about to hop in my car and head to the airport to go to the annual ASEP meeting as well. And this is a case that he had during his overnight shift as he signed out to his colleague. And here's the EKG. It looks pretty straightforward, right? This is a no-brainer lateral wall STEMI. In fact, the EKG machine's helping you out with the interpretation. The EKG machine interpretation is even saying, call the cath lab, give lytics, piece of cake. Sometimes people refer to leads 1 in AVL as the high lateral part of the left ventricle. So you could look at this and say this is a high lateral STEMI. And that's what the machine's calling it as well. So what do? Activate. Hold on there for just a second. When you get a 12-lead EKG, don't just jump to conclusions. Don't just jump right away at the most obvious diagnosis. I think it's important to always have a checklist or a method or a way that you interpret every single EKG. Some of you may have learned, rate, rhythm, axis, intervals, hypertrophy, infarction, whatever it is, whatever book you learn from, whoever taught you, use the same method every single time. Don't just jump to the most obvious diagnosis, or you might, in some circumstances, miss something. So tell you what, before we activate the cath lab, what I would recommend doing is just taking 30 seconds and really taking a look at the full EKG to make sure you're not missing anything else. And with practice, this really is a 30-second method, if even that long. We're going to go through this in more than 30 seconds, but with practice, again, you're going to get through this pretty quick. So first of all, let's look at the rate and rhythm. If you look at lead V1, which is the lead I like looking at to start with for rate and rhythm, it's pretty obvious that this is a sinus rhythm. There's P waves before every QRS complex. The P waves look to be upright in the key lead, so we'll call this a sinus rhythm. And the rate is 300, 150, 100. Wait, I'm doing that wrong. 300, 150, yeah, about 100. So the rate is about 100, so we'll call this sinus tachycardia. Okay, easy enough. Now, what about the axis? The axis is a bit unusual. This is a right axis deviation. We're going to come back to that. And then looking for ischemia and signs of infarction. Well, we've already kind of jumped to that. We've got ST segment elevation in the so-called high lateral leads, and we've got ST segment depression in a bunch of other leads. This is clearly an acute ischemia case with what appears to be a lateral wall infarction. Now let's go back for a second to axis. We identified an abnormality, and whenever you identify an abnormality, you've got to stop for a second and think about the differential diagnosis for that abnormality. What's the differential diagnosis for a rightward axis? After all, even though most people tend to ignore axis, I want you to pay attention to it. And when you see rightward axis, there's actually not that many things that give you a rightward axis in the emergency department. Now, don't be intimidated by this slide. A bunch of these things are pretty simple and tend to be fairly chronic. And therefore, chronic, in my mind, means not that relevant to emergency medicine. Right ventricular hypertrophy, for example. Well, right ventricular hypertrophy generally is going to give you tall R waves in lead V1 and fairly larger S waves out laterally. So, tell you what, let's cross right ventricular hypertrophy off the list. What about left posterior fascicular block, something that we don't really care that much about? Where's that EKG? There. Left posterior fascicular block, well, that'll give you a rightward axis. And we've talked about this before. We'll talk about it again. But one of the things that left posterior fascicular block does is it gives you little Q waves and big R waves in all of your inferior leads. And you've got decent sized R waves in 3 and AVF, but there's no Q waves there. And lead 2 definitely is no Q wave followed by a big R wave. So, you know what I'm going to do? I'm going to take the liberty of crossing left posterior fascicular block off also. What about dextrocardia? Well, dextrocardia is really easy to rule out. You know how you do it? You ask the patient. You simply ask the patient, has anyone ever told you your heart's in the wrong place? Most people who have a heart in the wrong place kind of know about it. You can always use this really old thing this instrument that what's it called? Oh, stethoscope. Yeah, you could use a stethoscope and take a listen to where the heart is. You can do this thing that they used to teach back in medical school. Maybe they still do. Feel for the point of maximum impulse, the PMI. Anyway, there's some simple things. You can even get an x-ray and rule out dextrocardia. So tell you what, let's take dextrocardia off the list. Lateral MI. Okay, that's obviously what we're most concerned about. If you have a big lateral MI that's already cued out, then that'll give you a rightward axis. But, there's something funny here about this so-called giant lateral infarction. If somebody's got such a huge lateral infarction to give you huge Q waves in these leads, how come you're not seeing Q waves in these lateral leads also? So, tell you what, I'm going to put a suspicious question mark next to that, although, yeah, we're still thinking about that. Okay, what else is on that differential? VTAC, well, let's rule that out. There's obviously no ventricular ectopy here, no wide QRS complexes. Hyperkalemia, there's no peak T waves or widening of the QRS complexes. Sodium channel blocker toxicity, tricyclic overdose and such. Nothing in the history to suggest that. That can give you a rightward axis, but usually QRS is a little bit wider. And anyway, nothing in the history. I'm not trying to hide anything. And acute PE, well, PE can certainly give you a rightward axis because it gives you that classic S1 and then Q3. That's pretty bad, but Q3 T3. Let me get rid of that. It's so bad. So S1 Q3 T3. But a large PE would probably also a large PE that's causing a rightward axis would probably give you also maybe an incomplete right bundle branch block type of pattern. Probably you'll see the flip T waves in the inferior and anteroseptal leads. You don't see any of those things. So just an isolated big S wave or Q wave in 1 or AVL, probably not. All right, I'm a little skeptical of that. So I'm going to cross PE off the list because this EKG is not screaming out PE. Misplaced leads, always on the differential. And so we've got two things to think about, misplaced leads and lateral MI. And I've already cast some doubt on this concept of misplaced leads. So let's move one step further along. One of my colleagues, Dr. Michael Whitting, who I forward this EKG to a bunch of people, and of course, Dr. Whitting is our research director and a super, super smart guy. In fact, he's got a brain that is just, well, I'm not going to go there, but it is huge. And he's also on the editorial board for the Journal of Emergency Medicine. And given that he's pretty much memorized every publication from GEM, he immediately sent me this article from 2009. So that's how big this guy's brain is. Anyway, he pulled this article within 10 seconds and sent it to me. And it was an interesting article that I hadn't seen before, but it talked about the relationship between leads AVR and V6. Probably a relationship you don't really think a whole lot about. But one of the things that this article pointed out is that normally lead AVR goes down and normally lead V6 goes up. If you ever see AVR going up, chances are you're going to see V6 going down. In other words, AVR and V6 tend to have an opposite vector from each other. They're opposite. And if we go back to this 12-lead EKG, where is it? All right, let me erase that. You see AVR is going up and V6 is going up also. That's not right. There's something going on here. There's something a bit abnormal about that. So that really pushes us further in the direction of saying there's something screwed up about the lead placement. So tell you what, when you're worried about lead placement abnormality, when things just aren't making sense, when the vectors are not making sense, you go back to your days back when you took physics and there's some inner physics sense to say vectors are not right here. What do? You know what? Repeat the 12-lead EKG, and that's exactly what Drs. Fox and Musi did. And voila, the ST segment elevation MI is officially treated and resolved. It works better than lytics. Just repeat the 12-lead EKG, and they suddenly reperfuse, right? Well, it turns out that this wasn't a STEMI at all in the first place. When you fix the lead placement, The ST elevation's gone. The leads now make more sense. There's a normal axis now. I like seeing that. That makes a lot more sense. There's no bizarre axis or no bizarre Q waves. Now, some people might look at this. There's clearly cardiac ischemia here, so we're not sending this person home. There's ST depression in a whole bunch of leads, right? So this person's clearly coming in. But there's a big difference between calling something diffuse ischemia versus calling something STEMI. With STEMI, if it's 2 o'clock in the morning, you're waking up the cath team or you're giving lytics. With diffuse ischemia, you're treating the patient with anti-anginal drugs, your nitrates and your antiplatelet agents and all those other things. So there's a big difference here. And the last thing you want to do is to call the cath team in only to be embarrassed because you got a 12 lead which had lead misplacement. Now, some people I show this to look at this and say, hey, wait a second, there's ST elevation in AVR. Doesn't this patient still deserve to go to the cath lab? To which I would say, well, maybe. Okay, that's not really the point of this whole case. The point of this case is to point out the differential for a rightward axis and also lead misplacement. But if you want to get into the nitty-gritty of AVR, this is how I see it. These two beats that I've boxed in, there's a lot of artifact. There's kind of a wavy baseline in there. This is the beat that I'm going to look at, which to me represents lead AVR, because there's no artifact, there's no waviness of the baseline there. And I think if you simply look at this beat right there, it doesn't look like there's all that impressive ST segment elevation in AVR. I usually worry when there's 1 to 1.5 millimeters of elevation in AVR. And these leads, you know, there's a lot of artifact going on. Oh, my battery is going to die pretty soon. We'll get done with this quickly. So lead AVR, you know, it may be of concern, but again, the key thing here that I want to point out is you've got to take a look at rightward axis and fix the leads. All right. Now, lead misplacement is pretty easy to miss. In fact, we missed it on the September 16th, 2013 case. If you go back, this is a case that was sent by Dr. Trejos, and we primarily focused on the AV block here. There's clearly an inferior wall MI, and we also pointed out that there is maybe a lateral MI and a big lateral MI there. But take a look. This person's got rightward axis again. We didn't really give that more thought, but we should have. And the other thing that doesn't make sense here is if you have an inferior wall MI, you probably ought to have a lot more ST depression in AVL. And also, what doesn't make as much sense, usually the ST elevation in lead 3 is greater than the ST segment elevation in lead 2. In this particular case, it's the other way around. Now, that can sometimes occur, but you just got to be as suspicious of it. And then finally, something we referred to in the previous example. If somebody's got a lateral STEMI that's producing these large Q waves, you probably ought to see fairly large Q waves in the other lateral leads as well, and you really don't see that at all. Right here, there's an R wave followed by an S wave. There's no Q wave there. There's no giant Q wave there. There's no giant Q wave there. So it doesn't make sense that you would have a big infarction Q wave in just that one lead. So along to our rescue comes Vince DiGiulio, who is a pre-hospital care guru, and he has his own website with some great things on it. Check it out. And he said, you know what, there's probably right arm and left arm lead misplacement. And if you fix that, then there's a whole bunch of things that get fixed also. 1 gets flipped, 2 becomes 3, 3 becomes 2, AVR becomes AVL. And if that's a little too hard to imagine, no problem, because what Vince did is he cut up the EKG image, he made the appropriate flips, and this, folks, this is what the EKG should have looked like if the right arm and left arm leads had been properly applied. All right, and so now ST segment elevation in 3 is greater than in 2. That makes sense. Now there's no giant Q waves isolated in 1. That makes sense. Now there's no longer that big rightward axis in lead 1. And also now you see nice ST segment depression in lead AVL, which is typical and expected when you've got an inferior wall STEMI. So, you know, in this particular case, the STEMI didn't go away. The patient still needs treatment with cath or lytics. And so, you know, the lead misplacement here didn't really make any difference, except that it's nice practice to pick up lead misplacement. All right. So my thanks to Vince for correcting us, pointing out that mistake that we missed. So quick take-home points. Right axis deviation, RAD. RAD is not normal, especially in emergency medicine. All right, whenever you see rightward axis, right axis deviation, think about the differential diagnosis that we went through and pay special attention to lead misplacement when the vectors just don't look right. Especially when AVR and V6 are heading in the same direction, something's wrong. Check the leads and repeat the 12-lead EKG. You may be surprised at what you end up finding. You may end up treating a STEMI. Go figure. The STEMI resolved. All right. So again, thanks to Dr. Sean Fox, Dr. Musi, and also Vince DiGiulio for their help with these cases. And looks like I got 7% battery life, so I'm going to wrap it up here. Remember, you've got to be the best at EKGs. The last thing you want is to call cardiology, have them come down and tell you that you didn't get a proper EKG because the leads were mixed up. So pay attention to those vectors, and when things don't make sense, just repeat the 12-lead EKG. Be the best at EKGs. I hope that was helpful, and I look forward to talking to all of you next week. I'm going to charge up. Bye for now.